Well, welcome to Touching Lives and to our second episode, Why Healthcare Decisions Matter. My name is David Edwards. I'm the Director of Communications for LifeTouch Health, and I want to welcome you to this first episode in our beautiful new studio here at LifeTouch Health. We're so excited about it, and in a future episode, we're going to talk more about that. But to get directly to matters, today I am joined by our President and CEO, Dr. Brian Bell. Thank you for having us here today.
That's one of my favorite subjects. I love our new studio.
Oh, it's
Y'all did a great job.
Yeah, and there's more to come on this, too.
All right.
Well, at the time of this recording, it is April 16th, National Healthcare Decisions Day.
Yes.
So I'm going to open up with this question.
Okay.
If something were unexpected were to happen to you,
Okay.
and you couldn't speak for yourself,
Yeah.
who would make your healthcare decisions?
Oh, yeah, that's an important question. Yeah. So today it'd be my wife. So my wife would make that decision. Now, I think that's different for everybody. I'll just be honest with you. It doesn't have to be your spouse. It could be your children. It could be your next door neighbor. It could be your pastor. It could be anybody you trust that you have a good relationship with. But, you know, a lot of times people do, as I do, to pick our spouses to do that. And I think that's a great choice. They're usually with you and around, and y'all having conversations. And so I think that's a natural choice, but it doesn't always have to be that person. It depends on a lot of factors.
But it doesn't just happen. This has to be recorded somewhere, doesn't it?
Sure,
So
yeah.
how does that, what do we do about that?
Yeah, so, I mean, there's steps to this. For when you're making these important steps, there's steps to first make the decision. Well, you know, what do I want? And then I always say, go ahead and then talk to that person who you want to be your proxy, your healthcare power of attorney. And probably at the same time, put those down in documents, written documents called advance directives. And so now you have a person, and within those advance directives, there is one document called a healthcare power of attorney, and that names who that person is, that in the case that you were unconscious, you could not speak for yourself, this person would stand in to speak for you. But that person would only come in to speak for you if you were in a state where you couldn't speak for yourself. So you couldn't sign this document and they go ahead and make decisions while you're still conscious and still have what we call decisional capacity. And then, like I said, the second part of that is an advance directive, which is actually the written kind of document that kind of explains in different scenarios what kind of care you would want to receive. And so it's very explicit and about what you would want. So then your power of attorney, your proxy or your durable power would take that document and know what to do. So it's written down. So it's very easy. So it's conversations and it's documents that work together to really do this decision making.
Okay. So you're CEO now, but you've had years of practice as a physician. Sure. From your experience in those years of practice, what difference does it make when someone has these plans in place versus not? And I'm sure you've got stories to tell, too.
Man, I could sit here all day with stories, but it's when we have a document, when we have a designated person who's been talking to that person, it's so much better when we have to make a very difficult decision. If there's a decision to take someone off the ventilator, breathing machine, or take them off life-sustaining treatment, that is not an easy decision to make without some kind of guidance. And I can tell you, I'll just give you one little story. I had a lady who had to make this decision for her mother. And a couple years later, she had to do it for her father. I wasn't there for her mother, but when her father was in the ICU, physically, she could not come up the stairs at the hospital to the ICU because she had PTSD, literally post-traumatic stress disorder from that experience. So I had to meet her in the lobby of the hospital just to have this conversation, because the first time we didn't have advanced directives, and unfortunately we didn't have it on the second time either. But it can be very stressful. Now, on the flip side of that, when I have those documents and we know known wishes, the peace that families get is incredible. That they're knowing they're not making a decision, they're just carrying out a decision that had been made already by the person, their loved one that was there at the bed. So it is, having and not having it is a dramatic difference of the experience that that person that's being there for that is going to have.
Okay. Well, you actually beat me to the punch.
Yeah.
One of the questions we're going to ask, what happens to when those decisions haven't been made yet? It's not a good situation.
It is not a good situation. It can cause a lot of harm for many years if those decisions for certain people.
Okay. Well, there are a lot of people that think this is something that just kind of like making a will. Well, I'll do it someday when I get older. When should someone make these decisions?
Well, what they tell us is 18 years old.
Really?
Or if you're an emancipated minor, you should have advance directives. So starting at 18, or if you're 16 and you're an emancipated minor, then you should have these decisions, having an advance directive, having a healthcare power of attorney. So it's not for, just the senior crowd. It's not for the no hairs or the gray hairs like us here. It is for pretty much anyone that's an adult needs to have these documents, and then needs, like I said, I tell you, having that person as your power of attorney is probably, for me, is even more important, that you can have a conversation. So yes, the documents are important, but I always say the conversations that you're having regularly with this person that's going to be your power of attorney is hugely important over time, because things change over time.
Okay. Also, so basically, if you're a responsible adult, you need to have these decisions made there.
And I wish I said when I was 18, I did it. I didn't. It was not the first thing on my mind at 18 years old, and probably not on most 18 years old, but that is the current recommendation at this time.
Okay. Well, we hear terms like advance directives as part of healthcare decisions, and also this term POLST comes up. What's POLST?
Yeah, and that it's somewhat different than an advance directive, and we'll kind of, in a little bit, it stands for Physician's Order for Life-Sustaining Treatment. Now here's the catch there. It's an order, right? Advance directives are more like a wish, but a physician order is very powerful. So when you do an advance directive, you sit down with maybe yourself or your family and you write it all out. With a POLST, you sit down with your physician to do this. Y'all discuss that, and that physician should talk about your diagnosis, your prognosis, what your options are. So it's a conversation not with your family members now, it's a conversation with your physician, because now on an advance directive, you're signing it, or some witnesses, and you, with a POLST, your physician now is signing it. So that is the difference. And the great thing about a POLST, and I love the POLST, I've been working with POLST for many, many years, is that it's portable. Meaning when you go to the hospital, it's going to work there. If you leave the hospital in an ambulance, it's accepted there. If you have to go to a nursing home. So this document's very portable and can go wherever you go. And you don't have to keep having these conversations, because it is a physician's order, which, like I said, is a very powerful thing, that is a portable document that travels wherever you're at. And should be acknowledged by another doctor, the hospital, the nursing homes, the EMTs. All the people recognize that document as a legal document that they need to follow.
So I guess to summarize it all up, no matter what stage you're in, get your advance directives.
Get your advance directives
done now, and then give serious consideration to your POLST.
POLST, yeah. And I'll say this on the POLST, the way it's written in the legislature, it's mainly for those people that have a year or less.
And we're talking specifically about the state of Arkansas?
Particularly the state of Arkansas, there's a legislature that came out in 2017, and in that legislature said this is really intended for those with a year or less. So now, can you do that? You can do whatever you want, but that was the intent of the legislation, is for that POLST form to be used for someone probably a year or less.
Okay.
And the other thing I want to say that is, make sure that your POLST form and your advance directives match each other. It can get very confusing if we have a POLST form that says one thing and an advance directive that says something else. So always make sure that those documents have the similar language or identical language, so that we're not confused about really what you want. So if you update one, make sure you update the other.
Keep them together and keep them available at home.
Keep them available at home, but also disseminate them. So you need to keep the original, okay? But you need to make sure, whether it's an advance directive or a POLST, that your physician has it, your hospital has it. So these documents are not good in a safety box, right?
Right.
They're not good if you don't give them to your power of attorney. So they're worthless if you don't have any way to disseminate them and put it in the hands of the people at the time that need to make these decisions. So I think that's another very important thing to consider.
Awesome. Well, it's great information. Hopefully it's a way we can positively touch lives, which is what we're here for.
Sure.
And I want to let everyone know that these forms for the state of Arkansas are available on the LifeTouchHealth.org website. You simply go to LifeTouchHealth.org/health-care-decisions, or you can just go to the click down menu under patients, scroll down, and the healthcare decisions tab is there. Yeah. Dr. Bell, thank you for being with us. We'll be right back.
All right, thank you.
It's time to party at the Plaza. Saturday, April 25th, 1:30 p.m., Argenta Plaza, North Little Rock, starring a family reunion of performers. American Idol winner Chris Allen, the Cleverleys, Rodney Block, Janine Latrice Perez and The Sound, the Rocktown Sparks, and Shannon Boshears. There'll be food trucks, family fun, the Care Fair, and more, all supporting the mission of LifeTouch Health. And admission is free. Visit partyattheplaza.org for more information.
Healthcare is changing, and Arkansas Hospice is changing too, impacting more lives in more ways. Since 1992, our trusted team has grown into the state's largest nonprofit provider of hospice care. Now, we've expanded our services into personal care, primary care, and palliative care, all with a new name, LifeTouch Health. Because when patients and families need more from us, we become more for you. LifeTouch Health.
Well, welcome back. On this segment, I'm pleased to introduce to you a couple of very special guests. First, we have Nikki Taylor, Vice President and Chief Clinical Officer for LifeTouch Health. And you all know Dr. Brian Bell, our President and CEO. Thank you for being on Touching Lives.
Sure, thanks.
Well, and as part of this segment, talking about understanding healthcare and healthcare decisions and how important they are, one decision that we know people encounter is, do you enroll in hospice or palliative care? And there's seemingly there's a lot of confusion and the blurred lines between what those two different types of care are. So people hear those words and they assume that they're the same thing, but are they? And Dr. Bell, you want to expand on that?
Yeah, so, and this is kind of how I explain it. So palliative care, well, let's say this, hospice is a subset of palliative care. So when you look at it, if you got draw a big circle, and this is a population of seriously ill people, within that circle is a smaller population that have a limited prognosis, probably for 6 months or less, basically is what the Medicare, hospice Medicare benefits. So there's actually more palliative care patients, but hospice is what I call a subset of the palliative care, and that's how most of the world looks at it. So I think there's a lot of overlap between the two. I think they both want to do great quality of care, and improve quality of life for patients. So I think that's kind of this common thread is that we're trying to say, how can we make people's lives better? Improve that quality of life, either that they have a serious illness or one that's, in the last couple of months. And so I think that's for me, a big differentiator. I don't know what you feel, Nikki. What's your thoughts about it?
Absolutely. Hospice and palliative do have the commonality of they're both specialties and they focus on quality of life and comfort. However, what I always want people to remember is that palliative care can be combined in alignment with curative treatment options. And so that's something that's important to remember, that patients can start that sooner.
So typically, palliative care first, then not all cases are the same, but then typically at some point in time it evolves into hospice care eventually.
Yes, sir. Palliative care allows us to start building those trusting relationships with specialists, and then they're followed throughout their journey.
Okay. So is there any time limit on the length of time a patient can be enrolled in a palliative care program?
No, sir. Once a person is diagnosed with serious illness, we're able to start that care then, and we're able to work with their current healthcare team, their specialists, whether that's oncologist, nephrologist, neurologist, and we can work in conjunction with their PCP as well.
So, and you mentioned that it can be in conjunction with curative treatment. So someone could be in palliative care and then discharge and continue a long life afterwards. So.
Yes, sir, absolutely. We actually have patients that are still undergoing home health treatment, physical therapy, dialysis, chemotherapy, and radiation.
And I think that's one of the goals, is really to make sure you get through your chemotherapy. Can you get through your radiation? So unlike hospice, you're going to forgo those sort of things to come on to hospice. With palliative care, you're going to hopefully complete all those therapies and when you're getting through that, hopefully do it better than you could without palliative care. So if you're having symptoms from that dialysis or symptoms from that chemotherapy, that palliative care provider is there to make sure you're comfortable while you're receiving those curative treatments.
Okay, so one of the things I want to ask about with that is we're talking about outcomes and quality of life. What is typically the difference between the outcome and the goals of care under a palliative care program versus hospice?
With palliative care, what we see is patients are able to decrease their hospitalizations and ED visits. When we proactively look for things like symptom management, shortness of breath, pain, and we address those proactively with a team approach, we can keep them out of the hospital longer.
Okay.
There's been some interesting research back in 2010 that patients that were getting palliative care that had a certain type of cancer actually lived longer, 2.5 months longer than a patient. So there is some evidence, and we see that, I'll be honest with you, you'll see that a little bit in the hospice too. We see patients have been researched, say, for heart failure, they actually live like 72 days longer than somebody who had the exact same disease but did not have hospice. And so I know it seems a little counterintuitive that would happen, but there is some evidence, especially with the palliative, this very great palliative, it's called the TIML study, showed that actually those patients actually live longer than the patients that did not have, palliative care.
So why do you think there's so much confusion on the differences between hospice and palliative care? Because I know a lot of times, even clinicians, they'll use the terms interchangeably, but we know there is a clear distinction between what stage of serious illness which one is appropriate for. So any ideas on why there's that confusion in place?
I think one of the reasons for the confusion is just the specialty of palliative and hospice separately requires a specialist, and in the state of Arkansas as well as across the United States, there's a shortage of these specialists, and I think that can compound the confusion. In addition, sometimes having difficult conversation is avoided, as many physicians may focus on simply treatment plans versus a holistic approach such as quality of life and comfort.
Yeah, I think some physicians, I'll just be honest with you, want their patients to be on hospice, but they use the word palliative care because it's just easier, right? And so if we're sitting here in a conversation and I'm fixing to have a conversation with you as a patient and say you're going to be on hospice, that's going to be a different conversation. It's going to be a lot of emotions. But if I say, hey, I'd like to put you on palliative care, it just really sometimes turns into a different, and I'll be honest with you, that confuses patients as well. And so I do feel like there's sometimes a choice that we make to interchange the word hospice and palliative care because hospice comes with some negative connotations, death, and so some clinicians, I believe, use palliative care interchangeably, which I think can really confuse patients sometimes.
Right. So one of the things that I want to ask about is what's the typical transition like going from palliative care and hospice care? When does that usually happen? And then are there any advantages to that being in a program where you already have a provider like LifeTouch Health? And is there an advantage of a more seamless transition from palliative care into hospice care with a provider like that?
Absolutely. With LifeTouch Health, we have providers at the bedside that meet you where you're at. And our visits last about 1.5 hours to 2 hours. So that provider follows you throughout the continuum of care. We're able to establish your medical records and your history and get to know you and your family and your goals and values. So when that time comes throughout the journey, we're able to help facilitate that seamlessly. So ultimately, we can focus and make sure that we're maintaining your ultimate goals and decisions as a priority.
So you mentioned the medical records and all, they're already in place. So that work is already taken care of, and it's just much simpler.
Well, it's what I call a warm handoff, right? Mm. You get referred from the hospital to a nursing home or from one doctor. They're not really talking with each other. So when you're under one umbrella, like we have in our family of services, you go to palliative care, we're going to warm hand off to the hospice services. You're going to get the records. Sometimes our offices are right across the hall from each other, so you can talk to each other. Hey, what's going on with that patient? So I think in medicine, that's really important, having those warm handoffs, because we know that transitions where people get into problems when they go from the hospital to, let's say, the nursing home or the nursing home to home, those transitions are the most troublesome. And same thing from palliative care to hospice. That could be a troublesome transition. But if you're in the same company that has these services, that's a much smoother transition.
And I guess with hospice or palliative care, you can still get those plans of care wherever you are, wherever your place of residency is, or whether it's your home, a nursing home, ALF, or even the hospital like that. One of the things that I would like to ask about that we haven't touched on yet is some more of the specifics in exactly the different services provided under palliative care versus under hospice care. Could y'all give us some specifics, please?
Sure. Yeah, so I think one of the things is palliative care is really a practice and hospice is a program.
Okay.
And I think that's one of the things you got to differentiate here. So it is a program with multiple, so for hospice, it's a program that's multiple services that are paid for. And
Such as, could you give us?
CNAs,
Okay.
respite care, medications, DME equipment.
So medications and DME equipment are paid
All
for?
covered
Okay.
under the hospice benefit, right? So it's a very comprehensive program. It's probably one of the most comprehensive programs the government has ever set up. And so you get all these nurses visits and you get 24/7 where somebody's coming out to your house in the middle of the night. Now compare that to palliative care, and I'll be honest with you, here's what I'm going to say about hospice is very regulated by the government. They have to follow very strict rules. Palliative care is very unregulated. And I always say, if you've seen one palliative care program, you've seen one palliative care program, because one program may do it this way, and there's no really set rules how to do palliative care, but you got to think of it as a practice. And so traditionally the practice, it's just like when you go to your cardiologist or you go to your primary care doctor. That provider's there. They're going to provide a service, the palliative care services, but it's not include the DME. It does not include the medications, because it's a practice and not a program. And so I always say that hospice is the Cadillac. My daughter would say is the Tesla. That's what I say now. But it is more comprehensive. Palliative care has a lot of the same, we have providers, but we do not have a lot of the other services because there's no palliative care benefit. There's a hospice benefit, but not, and so it acts more like a private practice. And that's just kind of the difference. And I'll be honest with you, it confuses people even here, because sometimes we'll discharge a hospice patient, right? And they have all these services, and we'll bring them on to palliative care, because think about it, 1 out of every 5 hospice patients in our organization gets discharged alive.
Really?
Yeah.
Okay.
Yeah, so, and that's, most people don't understand that you can get out of hospice alive. And part of that is sometimes you just do better, right? Yeah. You get all this great care and things are better. So they'll come into our palliative care program and they're thinking palliative care, oh, when's my CNA coming? Well, they're not. We don't have that. That's a hospice benefit. We don't have that. And so sometimes it can be, a little upsetting to patients to think they're transitioning to a program that would have the same kind of services. But but palliative care does a lot of great work. I'm not discounting the work. It does a lot of great work with advanced care planning, and they're available 24/7. So our team is available. You call, anytime you call, you're going to get somebody on the phone, a practitioner who's going to answer your questions. So they do act a lot of times really either on the front end to transition you, but a lot of times on the back end of hospice, they can be a transition, too, as well, so that before we had palliative care, we would discharge a patient from hospice and we would leave them with nothing, right? They would say, oh, you go back to your doctor, go back to this. But they did not get all what I call the gaps. There is a lot of gaps, things like advanced care planning, and let's talk about your emotional and spiritual health. Right. We still do that in palliative care. We just don't have it with all the interdisciplinary team that maybe the hospice program does, yeah.
So what is the optimal time to transition from a palliative care program? And let's say that it's a life-limiting illness, and we know what the outcome's going to be. What's the best time to transition? Nikki, you want to answer that?
Absolutely. What we see is when patients establish a 6-month trajectory and when they can utilize that interdisciplinary team, when care exceeds and needs additional aides and nursing staff with hospice, we want to create a smooth transition so that they get that benefit from an interdisciplinary team.
Okay.
And that palliative care team all along is kind of following you along, and we can document things that are going on like functional decline, cognitive decline. And so the great thing about it is that provider who's seeing you, maybe has seen you over the last 3 or 4 months and can really see like, oh, things are kind of not going the right way. And somewhere along that, in a visit, they kind of see, okay, we're at a point now where hospice could be an option. And they're probably already discussing it with you along the way, but
They're not pushing you into it.
not pushing it and saying, hey, this is probably going to be an option in the future. One of my jobs, one of the things that I do as a provider is say, hey, at that point, I'll let you know. I'll let you know when you're falling into that 6-month window, and then we can have a different conversation. And we'll have a conversation about hospice, and then, but the thing is what happens in the world without palliative care? You get treatment, and one day somebody comes in and says, you're hospice, right? Chemo, whatever you're getting, and it's just a 180 like that. That is what we know. That is traumatic. That can cause a lot of PTSD when patients have to make that 180 switch. But if you can ramp up to that, start having smaller conversations in the 6 months before that time comes, instead of all in one day it hits you, you've had a little time to prepare. You had a little time to think about it.
And caregivers.
That's what I'm saying, patients and caregivers. And so when that time does come, you've got now a person you trust, who's kind of led you along the way. The conversation is kind of thinking about that in the future. And when that time gets here, it's not overwhelming, right? It's not like you show up at your doctor's thinking you're going to get treatment today, and now they're saying you need hospice.
All right.
That is, I can't tell you how burdensome and heavy that is to someone to get that news that quickly. And without palliative care, I'll be honest with you, that is the normal way that happens. So palliative care changes what's normal to something I think better and improved.
Awesome. And to learn more about this, I just want to let everyone know, and I'm sure you can agree, you can go to LifeTouchHealth.org, click on the number to call, you can click on the contact us, email if you're uncomfortable talking to someone, and someone will be getting back in touch with you.
That's a good place to get it.
All right. Well, thank you so much. And we're going to take a quick break, and we'll be right back.
Healthcare is changing, and Arkansas Hospice is changing too, impacting more lives in more ways. Since 1992, our trusted team has grown into the state's largest nonprofit provider of hospice care. Now, we've expanded our services into personal care, primary care, and palliative care, all with a new name, LifeTouch Health. Because when patients and families need more from us, we become more for you. LifeTouch Health.
Welcome back. And right now, for this final segment of this episode, we're going to have a little bit of fun and talk about an upcoming event we have. But not to say it all first, I'm going to let these people tell us about it. We have our Vice President and Chief Philanthropy Officer, Dr. Kim Kirkman, and also from the LifeTouch Health Foundation, we have our events coordinator, Margaret Willis. Thank you for having us today. Okay, so for the listeners and watchers that may not be familiar, can you share a little bit about the big event we have coming up?
Sure. We're very excited. We have one signature event every year, and it's called Party at the Plaza. And it is on April 25th this year. And we are extremely excited to be able to support the mission of LifeTouch Health and all of the things that we're able to do with the revenue.
Okay. Margaret, do you want to expand on that?
Sure. So Party at the Plaza is coming up this next Saturday, April 25th. At Argenta Plaza here in North Little Rock, and it's a community event. First and foremost, it's free to the community, but we also celebrate our donors and our employees there as well. It's a music festival with 5 bands. We have headliner Chris Allen and bluegrass and comedy group, the Cleverleys, 4 or 5 other bands throughout the day. So the event starts at 1:30 and it's free to the public, and just come on out and have a good time.
Awesome. Well, I know that the primary focus is music. Party in and of itself, it says it in the word and the title of it. What about events, family-friendly events? What other kind of things do we have going on there for that?
Well, we have a care fair, and that has some displays of some of our lines of care. We also have adjacent lines of care that will be represented so that you can get a full range of what is needed in the aging process. We have a fun kid zone, face painting, bounce houses, and all sort of princesses and superheroes that are in attendance. There are some craft type booths as well.
Oh, well, I forgot to mention food. There's food trucks.
You got to talk about that.
Got to
Yes.
talk about some great Arkansas food trucks that'll be there and available for anybody that wants those as well, and beverages.
Okay. And from what I understand, it's come as you are, very free flowing, casual. Put on your cap,
Absolutely.
sunglasses, wear your sunglasses. You can
Yes.
bring your lawn chair. But are there any VIP ticket experiences available?
Yes, one of the really fun ways that you can experience this is through our VIP process, and it is a $150 per ticket, and you get snacks all day, beverages, adult beverages, and a full meal for dinner. So it's part of, we've added that for people that just want to come and enjoy the day and get to have a VIP experience.
Yes. And tickets are still available.
Yes.
Okay.
Yes.
And then what does the support from this event? I know that I understand it's sponsorships that are the primary funding mechanism, but how does participation in this event, both by attending and our sponsors, what does it do for the mission of LifeTouch Health?
That's a great question. One thing I would like to say is most events like this, the organization hopes to break even, but we actually raise funds that we are able to use in the foundation. We do have a cost to put an event on, as you can imagine, but we do exponentially have more money to be able to use for patients. And some of the things we get to do for patients, we have patients that have other needs besides their medical needs. Their insurance, Medicare, Medicaid pay for those medical needs, but people will often have a caregiver that has to stop working because they're caring for a patient, and their income is affected that way. And so we've helped people with nutrition, with insurer, or food for their family. We help people with emergency utility service when they get behind, and it's a crisis a lot of times when people are at the end of life, and we want to make this experience the best that we can for people. And so we're very generous to be able to help our patients in many, many ways.
Okay. And then how would, let's talk about the time. Did we mention the time? 1:30 p.m., I believe?
1:30 p.m. till
1:30
about
p.m.
10 p.m. And you can come, you don't have to come and stay the whole night. You can come for the meal. You can come for food trucks and enjoy the music. So.
Okay. And then this is an annual event. It's the 5th year, from what I understand.
Yes,
So one of the things that I would like to share is that in case someone's watching this podcast after the event has already happened, you can go ahead and start planning for year 6. We have a website that's up full-time on it. Margaret, you want to tell us about that?
partyattheplaza.org. There's all sorts of sponsorship opportunities. We have a huge video wall that we promote sponsors on throughout the event, and as well as our website as well. So there's lots of sponsorship opportunities, lots of ways you can honor and memorialize loved ones on a memorial wall. And we also give an award out every year to our Compass Award winner. This year it's Sharon Davis, and you can become a friend of Sharon or whoever's next year as well. And so there's lots of ways to get involved and to support this event. And you can volunteer if you just want to give your time. We would love to have volunteers as well.
It's just another way of touching lives, isn't it? Okay. Well, thank you for both being on here today. It's great to wrap up this segment of our podcast with it. And I want to thank everyone who watched. I want to ask you to make sure that if you're watching on YouTube, go and subscribe to our channel. Share this with other people. If you're listening online from whichever platform you listen to podcasts on, please share it with others. Thank you so much for your watching and listening, and we'll see you again soon. Thanks a lot.